Okay, let's welcome Dr. Jason Yan-Ping Ho, a fertility specialist who has completed his research fellowship at Stanford University. And he also taught in the Department of OBGYN in the China Medical University. And now he's the Vice President of Taipei Fertility Center. Today he's going to discuss about the Mosaic embryo, the strategy of a Mosaic embryo transfer. Please, Dr. Ho.
Thank you, Chairman. My name is Yan-Ping Ho from Taipei Fertility Center. My topic today is about the Mosaic embryo transfer strategy and update. It has been reported that chromosome instability is common in human cleavage stage embryos. An early study showed that only 9% of IVF embryos have a normal karyotype in all blastomeres. Such embryos have high rates of mosaic aneuploid, meaning that only some early blastomeres have abnormal chromosome number, indicating that mitotic non-disjunction events are also common, at least in this in vitro environment. At the blastocyst stage, the incidence of reported mosaicism using NGS method is highly variable between clinics, ranging from as low as 2% to as high as 40%. However, the vast majority of clinics reported that mosaic embryos represent between 5 to 10% of those tested. The etiology of chromosomal abnormality in human pre-implantation embryos is multifactorial. Errors may be derived from the oocyte, sperm, or during the mitotic divisions underlying embryogenesis, while meiotically derived abnormality generally affect all embryonic cells uniformly. On the other hand, postzygotic errors lead to mosaicism. Mosaic embryos may have both euploid and aneuploid cells, or be entirely composed of abnormal cell populations. To date, several studies have provided critical insights into the series of events that lead to embryo mosaicism. During mitosis, non-disjunction leads to complementary chromosome abnormalities, that is, reciprocal gains and losses in independent blastomeres of the same embryo. Conversely, the detection of monosomies without reciprocal trisomies points to anaphase lagging. These findings have been confirmed on single cells obtained from embryo at various developmental stages using both fluorescent in situ hybridization and comprehensive chromosomal screening. Chromosomal mosaicism may also originate from trisomic or monosomic rescue involving a mitotic error that rescues in an aneuploid cell population. If both homologs are derived from a single parent, this event may lead to uniparental disomy, UPD, associated with rare imprinting disorders. Nevertheless, UPD has only been reported in a very small population of pre-implantational embryos, about 1%. Unlike the whole chromosome abnormality, segmental imbalances in the cells of pre-implantation embryos were revealed after development of advanced molecular cytogenetic techniques. In year 2000, two studies demonstrate that the occurrence of de novo chromosome breakage during the first few mitoses following fertilization. giving rise to reciprocal losses and gains of the same chromosome fragment in the embryo. This molecular karyotype of an embryo generated after array CGH showing segmental losses affecting the long arm of the chromosome. This ideogram shows that the location of chromosomal breakage sites observed in oocyte, the green lines, cleavage stage embryo, the brown lines, and the blastocyst stage embryos, the blue lines. Numerous breaking points formed hotspots at distinct locations on chromosomes. The black rectangle boxes indicate the break points corresponding to non-fragile sites in the human genome. The mechanism of segmental aneuploid is not due to meiotic error. Unlike the whole chromosome abnormality, this study showed that no significant correlation was observed between the rate of segmental aneuploid and advancing maternal age at all stages of embryo development, including fertilized egg, cleavage stage embryos, and blastocysts. Since Dr. Greco from Italy reported the first published study with healthy live births following transfer of apparent mosaic embryos by using array CGH-based PGT-A, they transfer 18 mosaic embryos and turn out with 6 live births, healthy baby. Although the implantation rate is lower than the presumed euploid embryo, this gave rise to a question of mosaic embryos, to transfer or not to transfer. Since the initial report, several other studies involving the transfer of large number of mosaic embryos have been conducted and reported, prospectively or retrospectively. From the transfer outcomes, compared to euploid transfer mosaic or mosaic segmental embryos, all these do give rise to healthy pregnancies, but may be associated with reduced implantation rate and reduced live birth rates and higher miscarriage rates. So, what is the rationale behind the procedure associated with mosaic embryo transfer? On one hand, the trophectoderm biopsy at blastocyst stage with the mosaic result does not necessarily mean that the ICM cells are also aneuploid, so-called confined placental mosaicism, CPM. On the other hand, a recent meta-analysis also points out that there is no uniform opinion on the ploidy concordance between the ICM and the TE. Although there is no direct evidence shows that human mosaic embryos have the ability to deplete the aneuploid cells in the mosaic embryos. A mouse model of chromosome mosaicism published in the Nature Communication did reveal lineage-specific depletion of aneuploid cells, and the mosaic embryos do have the potential to develop normally. By treating embryos with spindle assembly checkpoint inhibitor, the reversing, during the 4 to 8 cells division, they generate aneuploid cells, and they find elimination of aneuploid cells by apoptosis, and overall, the proportion of aneuploid cells is progressively depleted from the blastocyst stage onwards. Finally, the mosaic embryos have full developmental potential. With 74 low mosaic mouse embryos, the low mosaic embryos did have a high survival rate with complete cell rescue. As for the human material study, the observation of human mosaic embryo development in vitro shows that the proportion of mosaic cell decreases and the proportion of euploid cells increases as the embryo were analyzed at day 4 through day 8 stage, which also imply that the self-correction potential. An interesting study was reported to support the human embryos are able to expel abnormal blastomeres as cell debris. The blastocyst and its corresponding debris were separated and underwent whole genome amplification and analyzed. The 9 euploid blastocysts, 5 shows that aneuploid debris, and the other 4 shows euploid debris. This means that the debris could be aneuploid debris. In human mosaic embryo cell study reported by Dr. Victor, euploid blastocysts displayed negligible level of apoptosis in the TE as well as the ICM. Interestingly, a large proportion of mosaic as well as aneuploid blastocysts displayed medium or high level of apoptosis in the TE compared with euploid blastocysts. In the ICM, some mosaic and aneuploid blastocysts display low level of apoptosis and others display medium or high level of apoptosis. Together, these data suggest that levels of cell death are considerably higher in mosaic and aneuploid blastocysts when compared with euploid blastocysts. Back to the clinical aspect. The accumulation of experience from large series of mosaic embryo transfer may provide a practical reference for the clinician. The 100 mosaic embryo transfers study revealed that compared with euploid, the mosaic cohort has significantly lower implantation rates per embryo, as determined by the presence of gestational sac is 49.6% versus 38%. Mosaic embryo also result in significantly lower chances of developing a fetal habit is 47.1% versus 30%. A significant age effect on the success of mosaic embryo transfer is also observed. That's very interesting. When oocytes were retrieved from the patients 34 years old or younger, the clinical outcomes of their results, mosaic blastocysts, were significantly better than those retrieved from patients greater than 34 years old. However, in this study, we notice that the level of mosaicism failed to show a significant difference. This is the latest large prospective mosaic embryo transfer reports. It was reported in ASIM 2020 annual meeting involving 1,000 mosaic embryo transfer in 7 institutes. This is so far the largest series of mosaic embryo transfer report. It is a multi-center prospective study involving assessment of embryos obtained from about 2,600 PGTA cycles. About 12,000 blastocysts were analyzed by NGS, with about 2,000 mosaic embryo detected. Transfer of 1,000 mosaic embryos and their outcomes were compared to about 5,000 euploid embryo transfers as control. The results shows that in general, mosaic embryo transfer is less favorable than euploid embryo transfer. Compared to the euploid group, mosaic embryos had lower rate of implantation, that is 46% for the mosaic embryo and 57% for the euploid embryo, and low rates of ongoing pregnancy of all births. For the euploid is 52.3%, and for the mosaic is 37%. Rates of spontaneous abortion for euploids were 8.6% and were 20.4% for mosaic embryos, which is also significantly different. When only considering embryo with mosaicism involve at least one entire chromosome, that is, excluding the segmental mosaic embryos, the implantation and ongoing live birth rate were 41% and 31% respectively, which were significantly poorer than euploid embryo transfer. The spontaneous abortion rate were also significantly higher in whole chromosome mosaic group, which is 25%. Mosaic embryo with a euploid less than 50% had more favorable clinical outcomes than those contain more than 50% aneuploid. The implantation rate was 47.7% versus 35.8%, and the ongoing pregnancy live birth rate was 39% versus 24%. Both comparisons were significant with p-value less than 0.05. Interestingly, when only segmental chromosome mosaic embryos were included in the analysis, it shows comparable implantation rate and ongoing pregnancy live birth rate. Cases from mosaic of the segmental type had more favorable outcomes than cases from the whole chromosome mosaic involve one or two chromosomes. The implantation rates were 51.6% versus 43%, and the ongoing pregnancy live birth rate were 43.1% versus 34.7%. While complex mosaicism involving 3 or more chromosomes in 125 cases had the least favorable outcomes, experiencing implantation rate of 30.4% and ongoing pregnancy rate only 20.8%. Taking the percentage of mosaicism into consideration, evaluation of clinical outcomes when combining mosaic level and the mosaic type produces the following ranking system from most to least favorable. That is, euploid is better than segmental, low level or high level, then followed by low level mosaicism of 1 or 2 chromosomes, then followed by low level complex mosaicism or high level mosaicism of 1 or 2 chromosomes. Then the least high level complex chromosome mosaicism. The birth outcomes show that babies born from a mosaic embryo transfer are indistinguishable from euploid embryos. Prenatal testing of pregnancy from mosaic embryo transfer show that no incidence of mosaic that matched the PGTA finding, which support the notion that self-correction mechanisms were involved. And the society also comments on the mosaic embryo transfer. The PGD International Society renewed their position statement on the transfer of mosaic embryos in 2019 after their previous release in 2016. The recommendation for clinician is in the event of considering mosaic blastocyst transfer, clinician should initiate a new further PGT cycle to increase the chance of identifying a euploid blastocyst for transfer or transfer of a blastocyst with lower level mosaicism after appropriate counseling. Prenatal diagnosis is also very important. Prenatal diagnosis of fetus and placenta of any established pregnancy after mosaic embryo transfer is needed. NIPT analysis, placenta copy number of all 24 chromosomes is recommended. But simple 5 chromosome NIPT like 13, 18, 21, and sex chromosome may not be appropriate. Amniocentesis analysis is the most representative of the fetus genetics. According to PGT International Society statement, if a decision is made to transfer embryos mosaic for a single chromosome, one can prioritize selection primarily based on the level of mosaicism and then the specific chromosome involved. If there is a chance that between the transfer of 2 mosaic embryos with similar level of mosaicism, embryo mosaic for chromosomes that are associated with potential for UPD, severe IUGR, or live-born syndrome may be given lower priority. PGDIS also recommends that the review of Grady et al. In 2018 for information on specific placenta complications and fetal syndromes in determining which a chromosome may be associated with various disorders is recommended. On the other hand, the ASIM 2020 committee opinion indicated that the following parameter for risk stratification of embryos with mosaic result have been proposed. That is, by percentage of mosaicism, specific chromosome involved, monosomy or trisomy, whether full chromosome or partial chromosome is affected by the number of chromosomes involved. But however, no evidence-based classification system currently exists for prioritizing embryos based on this parameter was informed in this committee opinion. The ASIM also strongly recommend prenatal genetic counseling for the pregnancy resulting from the transfer of embryos with mosaic results, including CVS and amniocentesis. Additional analysis beyond routine karyotyping should be considered, including chromosomal microarray if a partial or segmental chromosome aneuploid is involved, and the UPD study depending on the chromosome involved, additional cell counts in an effort to identify lower level mosaicism. For most chromosomes, there is no apparent phenotype effect related to UPD. However, UPD of chromosomes with imprinted region has been associated with abnormal phenotypes. Specifically, regions of chromosome number 6, 7, 11, 14, and 15 are associated with non-imprinting disorders, while there is less consistent literature regarding UPD for chromosome 2, 6, and 20. This is the human disease associated with UPD, including maternal and paternal UPD type, such as Silver-Russell syndrome, Prader-Willi syndrome, Beckwith-Wiedemann syndrome, and Angelman syndrome. Once UPD is possible to develop after mosaic embryo transfer, SMP microarray is able to detect UPD in amniocentesis tests. For example, the UPD for chromosome 15 the power of combined use of B allele frequency and the log-R ratio is evident in the UPD-15 patient, where log-R ratio is normal, but the lack of heterozygosity indicates UPD with 2 copies of the same maternal chromosome can diagnose the UPD of 15. We still need to be aware that the birth of a baby with mosaicism resulting from a non-mosaic embryo transfer is possible. This case reported in the Human Reproduction is a 35% low mosaicism chromosome 2 embryo. Successful pregnancy achieved following the embryo transfer. However, the amniocentesis revealed a mosaic trisomy, 2 cells in 100 cells. Because the pregnancy went on because there were no pathological findings in ultrasound and the fetus showed no more growth. Finally, a healthy female baby was born at week 37. The peripheral blood chromosome analysis validated with FISH showed that 2% mosaic monosomy 2. This case demonstrated the need for close prenatal monitoring and the diagnosis by amniocentesis. The conclusion: transfer of euploid embryos should be prioritized before considering transfer of embryos with mosaic results. Patients considering transfer of embryo with mosaic results should receive full genetic consultation, including further prenatal examination and the diagnosis on genetics. Mosaic embryo transfer are associated with a lower live birth rate and a higher miscarriage rate. Mosaic embryo transfer is an alternative option if no euploid embryo is available. Segmental or low mosaic embryos are preferred if mosaic embryo transfer is considered. And thank you for your attention. And this is the final slides. And okay.
Okay, thank you very much, Dr. Ho. We have a few questions, but we only have about 1 minute. Let me ask, I think there's a question from Malaysia. We like to prioritize this question. So the question is asking about what is your view on blastocyst with isoblast? So debris are left behind in the zona, whereas isoblast is stuck in the cavity of blastocyst. So do you think this kind of blastocyst has some effect on the euploid or not?
Yes, it's a very good question. That the isoblast, because the evidence did not show the isoblast is a important character of aneuploid. So maybe further investigation can collect the isoblast cell or debris for karyotyping or the genetic analysis. Then we can answer this question.
Okay, thank you very much. Although we have a lot more questions to ask, but we have run out of time. Thank you very much, Dr. Ho. I think we will submit all the other questions after this seminar to you. Thank you very much for your comprehensive presentation. Thank you.
Thank you.